Hello, I hope you guys are doing great. I miss seeing everybody. I hope that everybody had a nice break and ready for a new year and a new start. So I'm trying to enlarge the PowerPoint slides, so we'll see if my computer catches up to me in a minute. But I hope you guys had a great one and are ready to start a new year and a new semester with some new material. So this is Rehab 1, and of course I'm Dr. Norris. Y'all know me. And we're going to start out talking about therapeutic exercise, health, and wellness. So throughout Rehab 1, we cover different topics like therapeutic exercise, balance, coordination, metabolism, like how our body breaks down energy and uses it on a cellular level. I would have to go through the syllabus to see what else we can cover. Aquatic therapy and aerobic training and the whole gamut of therapeutic activities and exercises. So we start out the first half of the semester, we're covering more topics like basic building blocks and foundational knowledge you need to be a good therapist and to be able to treat patients and understand why you're doing what you're doing, like why you do the exercises and how it's helping them and why you would pick this type of exercise over that, or how long to do an exercise prescription, how many reps, how many sets, how much time, frequency, all that stuff. So we build the foundation, the building blocks of how to do all that, and then during the second half, we go through the body by segments. So we'll do like spine, shoulder, elbow, knee, ankle, all that. So that's the second half of the semester. So first we do the building blocks, and then the second half we get specific for this body segment. Here's some conditions that would be common, and here are how we treat those using the therapeutic exercise and the foundational knowledge that you've gained throughout the semester. So that's how the semester will go. Please see your syllabus online to see specifics, what we're covering, topics we're covering each week, when our tests are, when our assignments are, all that stuff. So for this week, you just have this one play pause it to do, and if you have questions, please reach out. I know this week we're not having lab in order to kind of stay safe because I know the numbers are high, but if I'm not sure about next week. Dr. Feltner will keep you posted on whether we have lab or not next week. So make sure that you keep checking your emails before you just drive to campus, because there may be some changes the first few weeks to make sure everybody's safe and nobody's getting sick. So keep me updated if you have questions along the way. Everything should be in your syllabus, and remember, all the specifics about this course are in the syllabus addendum on Blackboard. All right, therapeutic exercise. We're going to start out with some definition. It's a systematic planned performance of body movements, postures, and physical activities. That's one definition of therapeutic exercise. Another is the application of carefully graded stresses and forces imposed on impaired body systems, specific tissues, individual structures in a controlled, progressive, safe manner. And that's really a little bit more specific to physical therapy, that you're putting stresses on tissues, most of which are impaired by some extent, and grading those stresses by progressing the exercise, the difficulty level, in order to build strength, endurance, and regain function. Therapeutic exercise is individualized, so it's not a one program fits all. You can't just say every knee patient with this condition gets this handout, go home, have fun. If it was that, it wouldn't be skilled and we wouldn't get paid. It's individualized. For this patient, they may be tight in this area and weak in this area. For another, it might be the exact opposite. And although there's some commonalities, there's some things that we see pretty frequently with different patients. There are differences in every single patient. Even if two of them have tight hamstrings and weak quads, one of those two might also have pain on the inside of the knee and the other have pain on the outside of the knee. Everything is specific to that individual based on their circumstance. Goals of therapeutic exercise: we want to prevent an impairment, improve physical function, reduce health-related risk, and optimize overall health status. The patient-focused is for us, so client-focused would be more for wellness or for a personal trainer or something like that, but patient-focused is with somebody who has a diagnosis. So something is wrong, and we're trying to improve that. So the goal is to improve function to prevent further disability for somebody with a diagnosis, versus client focus, you're just promoting health, you're promoting wellness, and it's for somebody without a diagnosis that you're treating at that time. So that's more for like personal training. Some of the components of physical function: we have muscle performance, cardiopulmonary, spell that wrong, endurance, no, it's just no space between it, sorry. Cardiopulmonary endurance, mobility, flexibility, neuromuscular control and coordination, stability, balance, and postural equilibrium. All these go into physical function. So we're going to start with balance and postural equilibrium. This is the ability to align the body segments against gravity to maintain an upright position and avoid falling. So you're standing upright, and even with little movements, you're keeping yourself from falling. It relies on sensory and motor systems working together. Remember, we've learned before, we have 3 balance centers: the eyes, the inner ears, and proprioception, the feedback from the muscles, particularly in the legs. All of those go together to create your balance and your equilibrium. Muscle performance is the ability of muscle to contract and create enough tension to perform a physical activity. It can include power, and remember the difference between just power and strength is power has a time component. So if you can lift 400 pounds, great. If you want to be a power lifter, you need to be able to pull it up quickly. That's really the difference between power and endurance, how quickly you're able to do that activity. Between power and strength, I don't know if I said that right, but endurance is how long the duration you're able to continue doing an activity. With cardiopulmonary endurance, this is the ability to perform moderate intensity, repetitive, but total body movements over an extended period of time. Great examples of these: swimming, cycling, running, something that you're doing for a long duration and repetitively using the whole body. Mobility and flexibility. Now, one thing I do want to keep in mind is typically when we write goals in PT, we talk about increasing elasticity or decreasing tone. We cannot have a goal specific to flexibility because that's more of a wellness type thing, that if you just want somebody to get more flexible and be able to do the splits, well, that's not a goal a PT is going to work on. But if you want them to have increased muscle elasticity so that their hamstrings aren't so tight they're pulling on their back and causing back pain, that is something we work on. So although it's very similar, and elasticity and decreasing tone would kind of fall under the category of flexibility, you have to be careful about your wording as far as insurance being able to reimburse your treatment. So just know that. But flexibility and mobility, ability to move or be moved throughout range of motion for functional activities. Of course, there's passive. So when someone else is moving a segment or another body part is moving a segment, that depends on soft tissue integrity and the ability to relax during the movement. So if you're mobilizing somebody's shoulder and it's only going this far, either the tissues are so tight that it's not allowing the movement, or they're in so much pain they're kind of restricting the movement. They're not able to relax enough to allow you to go further. With active mobility, the patient is moving it themselves, and that depends on their strength, their flexibility, and their neuromuscular activation. So with strength, let's say if they're really weak and they can't move it above gravity, you may be able to physically move their arm. There's nothing restricting it, no tightness or anything. But if they don't have the strength to pull it up, then it still limits their mobility. With flexibility, that again is that soft tissue being able to move throughout the range. It could be also capsular restrictions within the capsule that surrounds the joint that could be tight and restricted and limit the movement. or neuromuscular activation. So, for example, somebody with a spinal cord injury, they don't all of a sudden have an issue with every muscle below that injury. It's just that the signal is not getting through from the brain to that muscle in order to allow it to activate. So, in order to have active mobility, you need all of that. You need enough strength in the muscle, you need enough flexibility in the opposing tissues, and you need enough signal getting through to tell the muscle to move. Another component of flexibility is muscle tone, inflammation. These are things that kind of could limit or restrict the movement. Muscle tone, inflammation, scar tissue, bone spurs, all of those things can limit somebody's movement. All right, coordination and neuromuscular control. So this is being able to have the correct timing and sequencing of the muscle firing and the appropriate intensity of force to have an effective movement. So it's an ability basically to control your timing, your intensity, your accuracy of movement. So I had an example of this football player. In order to catch this ball at the exact spot they needed to, sorry, I don't know how to mute this. Okay. They needed to have the right timing, the right intensity, how far up to jump, where to put their hands, the accuracy of movement, how to place, how to get their arms together at the same time. Takes a lot of things coming together to perform that. And unfortunately, I don't got it. I'd be missing that ball every time. But coordination and muscular control are where that comes from, is that category. Stability. So it's the ability of the neuromuscular system to hold a sustained position. Ability to control a stable base during superimposed movement. So like, for example, this pregnant lady at the bottom, the bus is moving, but she's able to hold steady even though there's movement in the surroundings, or ability to remain steady while a force is applied. I thought this was a good example of that. The wind is a very strong force being applied. You can see in the background the trees are blowing every which way and the water every which way, but he's able to stay steady, mainly because he has a very wide base of support. And that is stability. Stress-force relationship. The more stress you place on a muscle, the more force it's able to withstand until a certain point. So if you're trying to get stronger, you need to lift weights, and the heavier weights, the stronger you'll get, unless you go too heavy and then injure yourself. So the point between getting stronger and injuring yourself is called muscle failure. So this poor guy, looks so painful, tried to go a little too hard and muscle failed and tore, looks like pec, probably biceps tendon too. Looks like a pretty intense injury with an intense amount of weight. That would be muscle failure, when you try and go too far, put too much load, and the tissues actually are injured. They tear. On the opposite end, if you're not challenging yourself enough, if you're not putting enough force on the muscles, then they will begin to degenerate. So that's the whole if you don't use it, you lose it principle. So this guy at the bottom is a nice example of that. Looks like he was in great shape, had nice muscle tone. Unfortunately, he had COVID, was hospitalized. You can't see in this picture, but below this, he has a feeding tube, and you can see he lost a significant amount of weight, primarily muscle mass. He didn't have a lot of fat to lose, it doesn't seem. And I believe the caption on this article said something like 27 days in the ICU or something like that. So there was a significant amount of time he was bedridden and he lost all that muscle tone. So what we want to do as therapists is find the correct amount of stress and force to make this healthy relationship. So we put enough stress to gain muscle tone without putting so much that it causes injury. And remember, even if you're not seeing this big, obvious injury like in this middle picture, there's micro traumas too. So sometimes if you overdo it in the gym and then you're sore for like a week, remember delayed onset muscle soreness is one of the signs of overuse, of doing too much. It's not just that you built up a lot of lactic acid. I mean, that should be out of your system within the first 2 days. So if you're having soreness for more than 2-3 days, then most likely you have micro traumas, little tears in individual muscle fibers. And if you push through that before it heals, you're causing a larger injury. You're not doing yourself any favors. Remember, for your muscles to build up, first they must tear down. So there's a certain amount of healthy muscle damage that they tear down just a little bit, and then you allow the rest, you allow the recuperation, the regeneration, and it builds itself back up to a larger, stronger point. But if you tear down, and don't allow that proper rest in between, you're going to just create an injury. And that's where a lot of chronic pain comes from. Here's just kind of visual example of the stress-force relationship. If you put too little weight, don't use it enough, it starts to degenerate. If you put just the right amount, it either maintains function or begins to build muscle. If you put too much, you cause an injury. So we want to kind of be in that sweet spot where we're gaining muscle, gaining strength without injury. Results of force on muscle. So once you are able to carefully grade stresses and forces, it allows for optimal function over the course of time in therapy. So I loved this picture of this lady. She looked good to me to begin with. But as she worked out over time, her body got more defined, it got more toned, more strength. And then after a longer duration of time, you can see even more muscle tone, muscle strength, definition throughout her body. Now, this was, I'm sure, just with like personal training type of activity. This doesn't look like there's any injury, but the same occurs with muscles that are injured. That, this didn't happen overnight. This was a long-term thing. So you have to carefully progress a patient slowly in order to slowly build and transform their body, not just to look better, but to function better, be stronger. These are the same goals as earlier. What we want to do is to prevent physical impairment, improve function, reduce likelihood of re-injury, and increase their overall health. All right, so here's just some examples of exercises that we can do and where they fall on this curve, with like breathing exercises, range of motion, posture training, all being at the very low end, and balance, muscle, aerobic conditioning, functional training starting to progress to more and more difficulty level, and more in that sweet spot of what we want to accomplish with our therapeutic exercise. Some safety tips: you need to use good form to avoid injury. If you use poor form, two things happen. You're putting your muscle in poor alignment, which could create more injury, but it can also build the wrong areas up. If you are using poor alignment, you could be building up an accessory muscle, an extra muscle that shouldn't be targeted during that exercise, rather than the muscle that you really want to build. We need to assess the patient throughout for signs of fatigue. What are signs of fatigue? Remember, muscle shaking, starting to use, so I'm using bicep curl because you can see me easily. So shaking would be one. Starting to use other muscles, like if you see them putting their back into it or pulling their shoulder up. So compensatory muscle involvement or activation. The ability to do less weight or not go through their full range of motion, before they were going all the way down, all the way up, and now they're just kind of somewhere in the middle, or they had to put that weight down and do a different one. All those are signs of fatigue. So if you look over and you notice that they're really not able to do the exercise with good form anymore, then the exercise is not doing them any favors. You need to change it or stop the exercise for that time period until they recuperate, so that they can do it with good form. Use good body mechanics. We want to assess that throughout and correct that when needed. Progress exercises appropriately. Remember, it's good to have kind of a slow progression and a steady progression, so we don't jump from bicep curls without weight to bicep curls with 30 pounds in a week's period of time. We need to slowly build up to that in someone with an injury. And then practice makes permanent. And this is important because however you learn an activity is how you're going to continue activity. That's why when you have your children learning sports and things, it's good to get them with good coaches who teach form and who teach the basic and the fundamentals of that activity, and not somebody who has them just out there running around playing without correcting their form, because eventually they're going to continue however they learned it. So if you learned push-ups, well, for example, with an arched back and with your hands in a weird position, and you do that and you practice push-ups over and over with that form, it's going to be harder and harder to correct that form, or a golf swing or a tennis swing or throwing a ball, any of those things. The more you practice it with poor form, the harder it's going to be to correct your form in the future. So it's really important to correct people's form as they're learning an activity. And the more they do it with good form, the easier it will become. Squats is an example of that. I can't do a good squat to save my life unless I'm like sitting in a chair and standing back up, because I fall over. But that's from years of poor form with squats. Disablement model, we've talked about that before. We want to be able to see patient as a whole patient and not just as a body part. So we want to look at how this condition affects the person's ability to perform necessary functional roles. So while we use the disablement model, it increases our holistic view of the patient, it increases functional improvements, and it increases the return to their prior level of function. So when a shoulder patient comes in, we don't just look at this is torn, this is loose, this is weak, this is tight, and only treat that. We start looking at they're not able to reach overhead to put away their groceries. They're not able to pick up their child in order to put them in their crib. And how can we break down that activity and start practicing and building up those things they need so that they can be successful at the things that really matter the most to them. I went to a therapist once for hip pain. They treated the hip pain, and they randomly, one day I showed up and she was like, okay, you're discharged today. And I'm like, what? And she's like, well, your strength has gotten better, and this has gotten, there's no more tone in this muscle, and the muscle imbalances are corrected. And I'm like, yeah, but the same problem I came in with, I still have. I can't walk more than this distance without extreme pain in my hip, and I can't do this anymore, and I can't do that. And she's like, well, you've met all my goals. Well, all of her goals were very specific strength and tone goals that had nothing to do with my function. My function wasn't improved at all. And if you do that, you're not really doing anybody any favors. If you only focus on, I want to improve what I want to improve so I can see progress, but I'm not giving you any function back, you're not helping them at all. So it's key that we see the whole person and really help them with what is important to them. All right, so the ICF model, it stands for International Classification of Functioning, Disability, and Health. And we've learned the ICF model. Remember, there's health condition, body structures and function, activity limitations, participation restrictions, environmental factors, and personal factors. We went into that last semester, but just kind of a refresher. While we use this system, it describes, classifies, and codes these different areas to help you see the person in a more holistic way. So this can help you if you're saying, okay, they came in with a torn biceps tendon and here's my goals, but you forget to look at what activities are they limited from doing, what participation restrictions do they have. They're not able to return to work, or they're not able to play this game with their grandkids, or whatever's important to them that they're now not able to do because of that torn biceps tendon. You start writing those down, making goals more driven towards their function and what matters to them. And you see what limits them, what restrictions. Maybe they had a recent leg injury and they have stairs and they can't get in and out of their home until they figure out how to do stairs. So now we really need to put that at the top of our list as priority to help them get up and down stairs. So I think you all are pretty good with this, with body structures. It's the anatomy, the anatomical body part. The function is the kind of the physiology, the systems that it's impairing. And we're looking at things that have significant deviation or loss. With activities, that's how they execute a task, little things that put together to make a bigger thing like reaching your hand to your mouth or brushing your teeth or combing your hair or buttoning a shirt, things like that would all go into the participation restriction of unable to get ready in the mornings independently. And so if their participation restriction is unable to play soccer, well, the activity limitations may be unable to run, unable to kick a ball, unable to stand for long durations, or fully weight bear on their foot. So those are how those categories are kind of separated. Environmental factors is really their surroundings, if they have stairs or not, if they have a car that is accessible or what's accessible to them in their environment. And then personal factors can be comorbidities, other health conditions that they have that affect this. It could be caregiver support, it could be work demands, it could be a variety of things that are specific to that person that does affect their overall treatment and their ability to improve. Factors that affect the ICF. So contextual factors, that's the entire background of an individual's life. It's their living situation. It's composed of their environmental and personal factors. So environmental factors, physical, social, attitudinal environment which people live. So it could be their house. This is a house that would be very inaccessible. Or it could be the people they live around, everybody around them has issues. There's no real support or help or no real urge or push, motivation to get better. Could be personal factors, so features of an individual that are not part of the health condition or health state. And I already said a lot of these, but it could also include age, gender, race, coping skills, habits, cultural differences, background, all that type of stuff. So all of these things go into how we treat a patient and how we create an individualized exercise plan to help them improve. All right, some of our key terms: health condition, functional limitation, impairment, disability. Health condition is can be acute or chronic disease. It could be a disorder that impacts a person's normal level of activity. It's characterized by abnormal findings on screenings and tests. It's diagnosed by a medical professional. And why it matters to us is we need to understand the level of impact the condition has on the person's function. So maybe their condition is clubfoot in the top picture, and they've got braces and they're still able to walk, or they are completely unable to walk because it's too painful. Maybe they have rheumatoid arthritis, as in the bottom picture, and it's somebody that just has the occasional pain, or it's somebody that has deformities that restrict their ability to sew or to do things that they love. So we really want to dive into that health condition and see what impact does it have on the patient. With impairments, consequences of the condition. So it could be signs and symptoms that the patient experiences. Most impairments are either acquired or congenital. So acquired would be something that they got along the way, like this bed sore. They didn't move enough and their tissue broke down and created a sore. Or it could be congenital, like maybe they were born with spina bifida and they've been paralyzed since birth. Primary impairments are directly from the health condition. So, for example, with spinal cord injury, the primary impairment is the inability to move the legs, versus secondary impairments occur over time as a result of that condition. So if the person didn't move enough, they could develop pressure sores or contractures or things like that because of the spinal cord injury. But everybody with a spinal cord injury doesn't have to develop those secondary conditions. If they move enough, if they are cared for in the right way, if they, really watch for skin breakdown and assess and prevent that, then it's not something that is just directly related to the condition versus the inability to use those muscles would be if it was a complete spinal cord injury. All right, more impairments. Why does it matter to us? What do we take from it? So our clinical assessment is key. We want to always inspect and review their medical history and make sure that there's no worsening of the condition or no signs of skin breakdown or of tightness, so that we catch something before it becomes an irreversible damage. So, we're able to move the patient enough and teach them and educate them and their caregivers on how to prevent these secondary impairments. You also want to recognize the functional relevance of the impairment, what they have now and future impairments. For example, if somebody gets really tight in their hip adductors, then, and let's say it's somebody with a spinal cord injury and they have to have a catheter or have somebody help clean up bowel movements because they don't have full or any control over urination and bowel movements. If their adductors, their hip adductors get really tight and their legs are kind of stuck closed, the functional relevance is that they may not be able to open their legs enough to properly clean them. Well, now we have another problem. We have urinary or UTIs, bladder infections. We have skin breakdown on their bottom because it's still wet, not getting clean. So you want to look and say, okay, for this person, this is going to be functionally what's really important. I need to make sure that I educate them and teach them proper ways of maintaining this. We treat the impairment, but that doesn't always mean return to prior level of function. So, for example, spinal cord injury will continue on that example. Even if we decrease their tone in their legs and allow them to have full movement of their legs, if the signal's still not getting through, they're not going to have any active movement. It may keep them with passive movement, which would avoid contractures and allow for increased function, but not return to their prior level of function. They may not be able to still walk because the diagnosis has not changed. We're just preventing further damage or further functional impairments. Activity limitations, so difficulty performing tasks or activities of daily living. It could be physical, social, psychological, and it correlates to the person's quality of life. If somebody has significant damage and now they're not able to interact with their kids or their grandkids, that could have a huge impact versus somebody else that could have maybe even a worse diagnosis or more limiting physical impairment. If they're still able to do those things that they love, it may not impact their life as much. And so we really want to look at each individual person, how their life is impacted, what activities they're limited in doing. So BADL is basic activities of daily living. IADL, instrumental activities of daily living. You'll just see these sometimes abbreviated. OTs break them down into those categories more often than PTs. A lot of PTs just include them all in the category of ADL, activity of daily living. And why do PTs care about activity limitations? Because we want to manage the functional limitations while respecting the global needs of the patient. So again, if we get them stronger and we get them more with less tone and more mobile, but we have not gotten them to a place where they're able to independently get in and out of bed, or where they're able to pick up a child or a dog or a pet or something that they've always been picking up, did we really help them? We might have met our own goals that we wrote for them, but if we didn't meet their goals, what was the point? So we really want to make the goals meaningful and functional for the patients. Recognize their social, their psychological influences that may affect their ability to function optimally. So maybe they could have the potential to walk again, but they just don't have the motivation. Maybe they could have the potential to improve, but nobody around them is supporting them or helping them, and they're so depressed or so frustrated with their current situation that they're kind of stuck. So helping them through those, or even just giving them the resources for that. We're not psychologists, but we could say, hey, you happen to have a recent amputation. There are amputation support groups. Maybe that would help you, contacting other people who are experiencing the same thing. And there is power in suffering together. There is power in knowing somebody else is going through this. I'm not alone in this. So that would be huge. And pointing them to the right direction, even if it's something that's outside of our scope. Participation restrictions. This is difficulty fulfilling personal or social responsibilities. This could be at home, at work, or in the community, at recreation activities, anything like that. If we improve their function, we improve their quality of life. And some of our assessments can include home environment assessments and providing resources like support groups. DME is durable medical equipment, providing equipment that helps them be more independent, all those types of things. So just because they have stairs to enter and exit their home and they are now in a wheelchair does not mean that they're restricted to their home and never able to leave again. A ramp could be built to allow them access in and out of their home without even a caregiver present. They can become independent with that. So looking at all the factors that affect their independence and trying to set them up for success, give them the most assistance and to allow them to be independent. All right, so for a patient with a spinal cord injury, they're paralyzed from the waist down, decide which category each of the following belongs in. So I'll give you a second to do this themselves, but the categories are the ICF. Hold on. Oops, I'm going to put exit. Let me go back to that so you see what categories. I'm on slide 26. Health condition, body structures and function, activity limitations, participation restrictions, environmental factors, and personal factors. So those are the categories that I want you to kind of put these in. And patient is no longer able to walk, patient is not able to feel or move their legs, patient is no longer able to work as a firefighter, patient is paralyzed in both legs. So I'll have you kind of think about this on your own, and then I can put a little comment in the play pause it about the answers to this. Here is another example for a patient with a torn ACL, which category each of these belong in. Patient has 3+ out of 5 strength in the right VMO. Patient with a grade 3 tear of right ACL. Patient's no longer able to play basketball for our high school team. Patient's unable to ambulate without an assistive device. Again, I'll put a comment in your play pause. All right. Use the disablement model. So how do we use it? We use it to provide evidence of functional gains through PT tests and measures. So we do an intervention, and then we look, did it decrease the physical impairment? Did it increase their function? And that's kind of proof of the effectiveness of the physical therapy. We also use the disablement model to assist in determining level of disability and sometimes to prevent disability. So primary prevention, remember, is prior to onset of disability. That is health promotion. So eating healthy is an example of primary prevention. In preventing heart disease, eat healthy and get proper daily exercise. Secondary prevention is either early screening or diagnosis. It reduces the severity. So a mammogram would be an example of secondary prevention, catching a cancerous spot early in order to reduce the effects that cancer has, how much it spreads or how large it becomes, how much of an effect it has on the overall system. Tertiary is limiting the progression of a current disability. So you find that you do have breast cancer and you remove the breast in order to decrease its spread, in order to get rid of the cancer. It's funny because I have somebody doing a goniometric measurement. I'm not sure why I put that picture, but I would say that would be could be primary prevention if you're doing, consistently doing range of motion. Could be secondary prevention if somebody has a contracture, or preventing contractures. If somebody has a disorder and they have increased tone, doing that in order to decrease that. But those are the types of prevention, and we use that in order to help a person get to their optimal level of function. Evidence-based practice. So conscientious, explicit, judicious use of current best evidence in making clinical decisions for an individual's care. So you look at, I would like to do ultrasound. Well, is there evidence that ultrasound really helps somebody with this condition? Let me look at the research and decide, is this the best treatment, or should I do just a hot pack, or should I do ice? Which one would really benefit the patient the most? You look at the evidence, look at the research that's been done, and you decide based on that evidence what would be the best way of treating this patient. So in order to use evidence-based practice, we have to identify the problem. We have to look through the literature, analyze the literature, and then integrate that analysis within our clinical expertise and experience, and then incorporate our findings into patient management, assess the outcome of the intervention, and if necessary, pose another question. So for example, I have a patient with inflammation. I want to put ice on it. I look and see, does ice help inflammation? I see that there's studies saying it helps inflammation in the shoulder and knee, but I can't find any evidence for, I'm making this part up, for it helping inflammation in the low back. So now I'm wondering, should I use the ice on this low back patient with low back pain, or should I look for something else? And if I don't think there's enough evidence, then I need to look, what are the modalities that could help someone with low back pain, and then go towards that. So you look through the literature, you see what it says, and you see, for this specific patient, do I think that that is the best, or do I want to look and open up my plan to something else that has more evidence that it's effective? And then once you use it, you say, did it actually help this patient or not? Because just because it helped the masses doesn't mean it helps everybody. All right, patient management model. So there is the examination. Now, most examinations are by the medical professional. PT can do examination to a certain extent, just depending on what type. Then there's the evaluation. So typically the medical professional will do an examination and write a script for them to see a physical therapist. The PT will then do an evaluation and make their diagnosis and write out a plan of care. In the plan of care, we have a prognosis, we have goals, we have a timeline of how long it will be take to carry out these goals. And then there's intervention, and that's where the PTA really comes into play, as the PTA can assist with all intervention. The referrals and the consultations are typically from the medical doctor. If the PT looks through and says, okay, this is not really a musculoskeletal issue, I think something else is going on, they may refer back to the medical doctor or to a specialist or something. And then as we're going through intervention, the re-examination is when the PT evaluates progress and outcomes and decides how the plan of care needs to be modified. So this has been helpful, let's continue this. They've really met this, let's start a new goal. Or this has not made any progress, let's try something different in order to make progress. So this is kind of how we manage a patient with patient care in general, and the PTA primarily focuses on the intervention. They use the plan of care to decide what intervention they will do, and the reevaluation and things to mold how they do the intervention and which intervention's best. But that is where their role comes in. All right. PT eval, they make a diagnosis, and the PTA really needs to understand how that diagnosis influences their approach to treatment. So it can help you formulate progression of therapeutic exercise. It could alert you to signs and symptoms to look for. As you progress treatment, it can inform you of secondary impairments to assess for, to educate the patient on, in order to prevent further disorder. So the diagnosis really kind of drives your treatment. But again, it's individualized, so two people with the same diagnosis will still have variability in treatment. Plan of care. It includes the prognosis, which is a prediction of what optimal level of function they could reach. It includes It is an agreement between the PT, the patient, and the whole rehab team. It has goals, outcomes, time frame, intervention, and a plan for discharge. The patient's goals should be considered when making a plan of care. Of course, the PT is responsible for that, but if they haven't considered that, I think I would be asking the patient questions about their goals just to make sure we're doing the right interventions. And their outcome should be directly related to the plan of care. If somebody creates a really poor plan of care, for example, the time I was talking about myself going to PT, where they only focus on gaining their own goals and not function for the patient, then it could lead to lost money, lost time, a window of opportunity. So let's say they're not pushing the patient enough and the patient develops scar tissue. Well, that might be something that they can't change in the future. They may never get full range of motion because we missed this window of when we should have really been pushing mobilization and we didn't. It could lead to further functional interventions. I know I've seen patients where they had a stroke and they didn't have a PT to go to, or they didn't get authorized through their insurance for 3 months. Well, the first 3 months are definitely the most important in functional gains for stroke patients, first 6 months for sure. And so it set them back huge and something that they may or may not be able to bounce back from. So it's important to have the right plan of care and to really improve the patient's function. Intervention, so we have purposeful interaction between the therapist, patient, and caregivers. We need to coordinate the plan of care. We need to communicate and document all the components of the intervention. Patient education is essential in the intervention. Sometimes they may be motivated to get better, but then they see all I'm doing is this same exercise over and over. Why? I don't get it. I'm not going to do that anymore. But if you educate them, hey, if you get this stronger, then it offsets this and it decreases this muscle imbalance. And now that's what's causing your pain. So your pain will be improved and then your function will be improved. You know, if you explain that in the right way, depending on their condition and their situation, then it may increase their motivation. Oh, okay, it makes sense. I didn't think that this did all that, but now I realize that now I'm going to do it. So patient education is huge in compliance and in motivation. The home exercise program, those are exercises given for them to do outside of the treatment. The therapist provides instructions during the treatment session, and then during follow-up sessions, you ask, what have you been doing at home? Show me, and you assess and see how are they doing. Are they doing it correctly? Is their form good? Are they doing it the right amount of times? And you make their recommendations based on that. Exercise instruction. So effective exercise instruction is based on a positive relationship between the therapist and patient, knowledge of their learning style, identifying their attitude towards exercise, properly progressing the exercise from least complex to most complex, motor learning, acquisition of tasks through practice, modifying how sensory and motor information is organized and processed. All of that goes into doing an exercise appropriately, and we're going to go into some of these categories more in depth now. So, different types of instruction. Discrete motor tasks. So that involves an action or movement with a recognizable beginning and end. So throwing the ball was my example. You start here, you end here. Done. That's a discrete motor task. Serial motor task. That's a series of discrete motor tasks. So cheerleading was a good example. So I'm doing a toe touch that has a beginning and an end, and now I'm doing a clap and a high V and a hands on the waist and a jerky. All right, I used to be a cheerleader. But it's been a long time. So it's a bunch of discrete tasks pushed together where you can say, that was this movement, that was a back handspring, that was a tuck, that was a round off. And now we put them all together, round off, back handspring, back tuck. And it's a serial motor task. It's several discrete tasks put together. With a continuous motor task, it's repetitive, it's uninterrupted movements that have no clear, distinct beginning and end. So a break dancer was my example of that. They're doing a bunch of movements. I'm sure they could name some of them, but for the untrained eye, it looks like a bunch of movements with no beginning or end. It's all intermingled together, and that is a continuous motor task. Stages of motor learning. So cognitive must be consciously thinking about what steps to do, like when you're driving and you're thinking, oh, I need to look in the mirror, and now I need to put my turn signal on, and now I need to pull the wheel this way or move my foot here. Versus associative, you start fine-tuning the learned task. So now I remember where my hands go, I remember what my foot does, but I have to kind of remind myself how far to turn the wheel or when to look this way or whatever. With autonomous, then the movement becomes automatic. So once you've learned to drive, you've been driving for years, you start thinking about other things. I need to do this, I need to do that. You look up and you're in the Walmart parking lot and you're like, oh, I don't even remember driving here. So those are the stages of motor learning. Cognitive, you're thinking about everything you're doing. Associative, you're starting to fine tune that and get things more consistent and better. And then autonomous, it's now automatic. You can do it with your eyes closed. You can do it with in your sleep, but I wouldn't recommend either. Learning acquisition. When you have a new skill, first you do cognitive learning. So that's a closed environment. You use it to increase the understanding of what to do, how to do it, and the reason behind the activity. Associative uses open loop environment to increase feedback provided to patient in order to improve their efficacy, their consistency during the motor task. And autonomous, the patient has learned the task, is able to perform it with little thought while doing another task. So in our practice, most of the time people are doing the cognitive and associative, and then they're discharged. And if they continue, they might get to the autonomous, but they may not. An example I had of this, it's the same thing we talked about last slide, but another example, my mom worked at a factory where she screwed on a part of a light bulb for years. And when she first started, she would have to think about, okay, I pick it up with this hand, I screw it this amount of time till I feel it click, and I put it over here. And then as she did it over and over, the associative, I do it again, and she's thinking it through, but she's practicing over and over. Eventually it became so autonomous that she said she could be basically sleeping with her eyes open and doing the job over and over. No thought involved. Pre-practice, you start to pay attention to the task. You might look at a demonstration and avoid over-instructing. So when you're first teaching somebody, have them watch it, maybe have them start, but don't over-instruct because that could cause discouragement. During practice, part practice increases learning initially, and then whole practice helps refine the learning. So part practice might be first do this movement, then that movement, and then reach it up. And then whole practice might be making it one steady stream of movement that's no longer broken down. The way that we can practice things, there's blocked, random, and random blocked. So blocked is like, for example, hitting a golf ball straight ahead over and over. It's doing the same thing. There's no variability to it. You're just trying to get good at swinging the golf club. With random, now you're hitting it to different spots, aiming it different ways. You've already got good at swinging, and now you're kind of perfecting your range and your ability to do different things with that swing. And then random block, you're kind of doing both. So just because you're a pro golfer doesn't mean you stop practicing your putt or practicing your drive. You still, sometimes you might go out to a driving range and just hit it over and over and just see, try and perfect your swing. Other times you might play an actual round of golf. Other times you might go putt-putt. I don't know if they still do that, and work on, that portion of the game. So kind of intermingling the random and blocked in order to really improve your practice and your success. Hierarchy of practice. So first, you have mental, where you visualize and you imagine. You think, I want to do this activity. Here's how I'm going to do it. So for golf, okay, I'm going to hold my hands this way. I'm going to hold the club this way. I'm going to swing this way. I'm going to keep this still and move this. And you're kind of talking yourself through how you're going to do it. And then physical is actually doing it. So when you're practicing, you need both. You need to kind of imagine yourself doing it, kind of talk yourself through all the steps, and then actually do it. With feedback, once you have done it, you need some feedback and see, how did I do? Intrinsic is from your own senses. Okay, that didn't feel right. That didn't look right. That didn't sound right. Extrinsic is from someone else. So you have a personal trainer there saying, okay, now push your butt back a little bit more in order to have keep your knees behind your toes while you're squatting. Or you have a therapist saying, now pick your legs up higher in order to clear the floor every time you take a step. That's extrinsic. Concurrent feedback happens while you're doing the activity. So in the first picture, he's lifting weights, and while he's doing it, the guy's saying, pull it up higher, move this way, relax your shoulder, whatever feedback he's given. Versus post response, you may take a video or a picture or just sit down and say, now I noticed while you were doing that, you were holding your breath. Make sure you breathe. The best type of feedback is intermittent, and I believe all of these components would go into it. So some while they're doing it, some after, some from themselves, some from others. But intermittent feedback is the best. If you're just constantly giving somebody feedback, move this, hold this, touch that, move that, then you become like the teacher on Charlie Brown, wah, 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 wah. But if you're breaking it down and you say, now lift your legs up higher, and you watch a few steps, okay, you drug the floor, lift it up higher, you wait a few steps. Oh, good job. Then that's the best type. Constant feedback is just too much. All right, desired outcome of action. So this is environmental condition. This is the outcome. So this is a chart we use to help us progress activities, and we'll probably work on this some in lab because it'll be easier to understand. There's two types of environment, closed versus open. I go into some of this in the future slides, so hold on. Closed versus open. Okay. So an open environment, there's change or movement of people, of objects, of surfaces. So for example, riding a bike outdoors. There's people moving around you. All of a sudden, somebody might cut in front of you. You have to really watch your environment, and you have to really pay attention to what you're doing in order to stay erect on the bike. With a closed environment, there's no movement of people. There's no movement of objects. The surface doesn't move. Everything is stable within the surroundings. So a stationary bike would be a perfect example. Although you're moving, the bike's not moving, nothing around you. If you're in a closed environment, then the TV's not distracting. There's not kids running around, and that's the difference. So the easiest is a closed environment, learning an activity in a closed environment. And then as you progress, you can begin to do that activity in an open environment. Intertrial variability. So let me go back to the thing. Let me see. Body stable versus body transport. I think I have, yes, on this one. I'll go ahead and cover this slide and then I'll go back. Body stable versus body transport. So body stable, no movement. Body transport, anytime a movement occurs, it's body transport. So my example, static balance, just standing still with eyes closed, is body stable. In order to make that task more difficult, you could have them on a moving surface like an escalator, or you could have them move their body, like rotate or move their head or reach for an object. So when you're progressing somebody, you can look at that chart and you can say they started out with no variability in a closed environment and stable. Now I want to progress them. I could either add some manipulation, I could add some variability in their environment or in the task, or I could make them move, make their body transport, or I could put them in a different environment where they had to focus more. And that's how you progress. And typically you only want to progress kind of one block at a time. You don't want to all of a sudden go from static balance to now they're standing on a moving surface with their eyes closed, reaching, and people walking all around them, because that's just too much. You want to progress one at a time. Intertrial variability. So present when changes occur between trials, environment is unpredictable. Low variability produces consistency. So like going to what is that called now? where you hit baseballs over and over. Can't remember the name for it, but going there and a machine is throwing a baseball at you, same speed, same place every time, and you're just hitting over and over, no variability. Versus a real baseball game where the pitcher is throwing different types of balls towards you, like curveball. I don't know what other types there are. What different types of pitches is what I mean. And throwing them at different levels and different speeds. And as it changes, it's harder to hit it. So when the variability increases, it increases your proficiency level. It makes you better. However, when you're learning a task, it's nice to keep it more consistent in order to learn it. Dimensions of task difficulty. So with or without manipulation, that's another area of that chart. Manipulation could be upper extremity movement, like a ball toss or not. It could be dual tasking, talking while you're walking, or carrying a tray, anything like that. So if you have an extra little something that's being manipulated in the environment, it increases the difficulty level. All right, just a few slides left to go. Health and wellness, you pretty much know about, so I'm going to kind of zoom through it. Some definitions. Health is your general physical, mental, and spiritual condition of the body, versus wellness is a good state of health. So healthy lifestyle leads to wellness, being in better shape physically, mentally, spiritually. Health promotion contributes to wellness, to the growth and development of your health. Health-related quality of life. This is the total effect of an individual and environmental factors on function and health. So I know last year my goal for 2021 was to get healthier because I was just feeling beat down and crappy. And I went to the doctor, had all these tests, and eventually got to a place where I was making some better choices and adding some things to some supplements and things to my routine, and doing things where I started to actually feel better. Woo woo. But and that increased my function. So that increased my quality of life. Fitness, physical activity, all of those go into health and wellness. I think you all are pretty in depth with that, but if you have questions on that, just let me know. Role of PT in health and wellness. So PTs can screen and identify individuals who would benefit. They can educate, provide information to patients. They could provide intervention like treatment programs, wellness programs. They could identify risk factors like with health screenings or risk assessments. They could consult and provide expertise and knowledge. They could do a critical inquiry where they use and contribute to research so that the evidence is out there on what's the best practice. They could do administration work. They could plan, develop, and manage wellness projects. I don't know if any of y'all have been a part of any PT wellness type incentives, but a lot of gyms will have wellness programs that you can join after you're a patient. So you come, you get used to the equipment, get used to your exercises there, and after your discharge, you can continue to come back for a low fee and do your exercises there. And although you're not under the direct supervision of a PT, the PT or the PTA is available to answer questions or to provide feedback on your form if you need it. So that's the primary role. PTs are getting more and more into wellness and into prevention, like fall prevention programs and strengthening programs like camps to focus on strengthening the gluteus medius and the VMOs in order to decrease female athlete triad or injury of knee injury or things like that. So that's become more of a focus, and more insurance companies are starting to pay for more wellness. But before, it used to just only cover more health related issues. So something we're definitely working on. Implementing a prevention program. So there are some behavioral change theories you can look into. I'm not going to really go into those or test you on those. But one of the factors I do want to talk about is motivation and self-efficacy. So getting someone motivated is really step one. If they have the potential to improve but no motivation, they're not going to get much better. And so really trying to change that I can't do it attitude to I can, and trying to show them sometimes your goals and your progress, just showing them that is key. For example, something you might be able to relate to if you're on a diet and you're not feeling like, I don't feel any better. I don't feel like I have more energy. It's hard to do. I don't like it. I don't feel like I'm losing any weight. My clothes are just as tight. And then you get on the scale and you see that you lost 3 pounds. It's like, oh, well, maybe this is working. Maybe I will stick to this. And so being able to show numbers and improvement that way is key. And that happens in your reevaluations or in between. If you measure and you say, look, when you came in, you had this much swelling, it was 12 inches, and now it's went down to 11. You've lost a whole inch of circumference and swelling. You're really getting better at that. Or when you came in, you could only bend your elbow to 90 degrees. Now you're able to bend it to 130. You've gained a lot of movement in your elbow. Because when you make little progress over time, sometimes you don't notice it. But then when you see before and after pictures of somebody that's been on a diet, you're like, whoo, that's impressive. Or you see before and after numbers of somebody who's been exercising or doing therapy, you can see this is worth it. Keep doing it. And then implementing a prevention program. When you're developing and implementing a program, it's all about goals. You assess their need. Remember, look at the whole individual and their function. You set goals and objectives. You develop the intervention. You implement the program, and then you evaluate. Is it effective? I did this with one patient and it worked great. I'm doing it with them and they don't seem to progress. What could I change to make it more effective? So that is your therapeutic exercise in a nutshell. Please, again, reach out to me with questions, with any concerns. If you have any questions on the Play Pause or whatever, you can email, you can text, and I will keep you all informed about next week, whether we're meeting in lab or whether we just have a Play Pause. We will have a Play Pause for next week, but we may also have 1 to 2 labs just based on what we do moving forward from, COVID prevention and all that. Have a great day.